Hi, everyone, and thanks for joining us today on Coding with Christine Hall. We had a little bit of a break for spring break, right? And I am joined today by my good friend, Kim Huey, and we're going to talk to you about ICD-10. Before we get started, I have to tell you it's National Burrito Day. So I know what we're having for dinner at our house tonight. Burritos. It's also National Parkinson's Month, and it's a great thing because Kim and I are going to be talking a little bit about mental health and the nervous disorders. So it's going to play in real nice. So thanks for being here today, Kim. I really appreciate it.
Oh, you're welcome, Christine. I look forward to chatting with you whenever we can. And coding's kind of my passion. You know, so
Absolutely. So, just to give a catch up for those that maybe haven't been with us for a while or new to us, this season we're going over the ICD-10 guidelines, and I preach a lot that the answer to diagnosis coding really rely on these guidelines, but they read like furniture assembly instructions. Have you ever been to IKEA?
hmm yep,
Yeah. Did you
yep,
ever put something from IKEA together?
right. My husband's in there
No.
right now assembling new lawn furniture, and
Okay.
yeah. So,
So then he knows
uh-huh.
exactly
Yep,
what's going on, right?
yeah,
And the
yeah.
guidelines, they remind me of that. You're like, wait a minute, A and B, and then B, wait a minute, B and A, which one goes first? I'm
hmm
not real
hmm
sure.
hmm
Um, and so that kind of rolls right into why I thought it would be nice if we could break down some of these chapters, just the things that are important, or explaining some of that guidance in real talk, in real language, like we
hmm
talk.
Exactly, exactly. And just the fact that still run across people who don't realize we have guidelines. What are they? Really? Um, and then the fact that, so many people have gotten away from using a book, and you heard me say this before,
Mhm.
yeah, encoders are awesome. They're wonderful, and they'll have the guidelines built in there if you look for them. But also, if you got a book, hey, they're in the book.
Mhm.
And then, of course, my favorite thing, what I prefer to do is just download them from the CDC website, have
Mhm.
them, and then they're PDF searchable. Um, but just to know they're there, I think is a big step for a lot of people.
I like knowing the rules. It makes my life easier
hmm
than having to guess. I don't know. That's just kind of my thing there. Now, Kim, have you heard that some of the credentialing organizations may are considering using ebooks for their testing as opposed to
I,
the book?
I'm just kind of wondering how that's going to work. I'm kind of a logistical person. I can't figure out how that's going to work. Yeah, I can see the benefit of it, but
Hmm.
you're probably like me. Carrying around, 40 pounds of books versus carrying around the laptop absolutely is easier. But I still do a lot of hands-on, heads down coding, not just consulting, but I do some coding. And there are times when that encoder won't do it. I just have to grab my book out of this cabinet up here where it stays and pull it out because I can get there.
Yeah.
Um, there are quite a few times when I can't get there in the encoder because I've not input the right word. But if I go to my ICD-10 book and I'll tell you the story,
Hmm.
yeah. So I used to have this joke that when I was teaching coding, if I caught you coding from the index and not going to the tabular and using the guidelines, I had a butcher knife in my briefcase and I would cut your fingers off.
See,
Well,
I make mine do a swear, put your hand on your heart and your other hand up and swear to me that you will never code from the index,
mhm,
right? So that way I can sleep well at night knowing that you've all pledged to me
mhm.
forever.
Well, I said this hundreds of times, probably hundreds of times, but I did it one time at the Gainesville, Georgia AAPC chapter. And the president of the chapter raised her hand and waved. She was missing 2 fingers.
Oh, Kim.
She laughed, she thought it was hilarious, but I don't tell that story anymore unless I tell the whole story,
Right.
because it was like, "Oh my goodness." Um,
I
I
bet she had a laugh though. I bet she
she Yeah, she thought it was hilarious. But yeah, so
Oh my gosh. Well, now I'm going to take that a little more seriously about those but the truth is I really feel that between now I feel that, first of all, I'm never going to memorize the guidelines. I read
Mhm.
them every single year. And if they have a change mid-year, like we had a change again this year in April 1st,
Right.
I'll read them again because I leave breadcrumbs in my mind.
Mhm.
I'm
Right.
never going to remember word for word what it said. I'm too old. There's not enough space in there. I know all the lyrics to like my favorite rock star song,
Mhm.
but I don't
Mhm.
know all of the, but I know enough. I have my breadcrumbs in my mind to
Mhm.
remind me that, oh, there's something about hypertension, or, oh, there's something about um, sepsis. Oh, I never
Right.
touch sepsis without my book.
Right. Right.
Never. Mm-mm.
Exactly. Exactly.
Yeah.
And talking about these chapters, I do a lot of work in the pain management space. I've had the fortune or unfortune, whatever, misfortune of working on audit defense for a couple of pain management, huge
Mhm.
pain management audits. I mean, like federal, um, um, False Claims Act. One of
Mhm.
them was like $8 million. So um, we've had to prove some diagnosis coding issues, and so I'm always, let's go see, and why can't you just throw out that G8 9.4 because it's not maybe not to be G8 9.4 and
Mm.
some of those things. And that brings me to the idea that we throw those on there without knowing what we're throwing on there, without knowing what it requires, and we can't without reading the guidelines and understanding those.
Absolutely, absolutely. And so this year we had a large amount of diagnosis codes that were added to chapter 5, the mental
Mhm.
health and substance
Right.
use disorders. So 82 new codes, 3 revisions, 4 converted codes. Um, and so that's a lot. But it really was surrounding dementia.
Mhm.
So
Right.
again, Parkinson's month. Thanks for
Mhm.
sharing that with me. Dementia, needing to understand, where did the dementia come from,
Right.
and
Exactly.
what is it doing, what manifestations do we see, and
Mhm.
what's the severity of it, so that we can start seeing either a progression
Mhm.
or maybe a regression if things are
Right.
working the way that they're supposed to. And it really broadened that category out of how to report dementia.
Mhm.
And I really, really thought that was very interesting.
Well, and a lot of that, what does it matter what we call it? Well, what matters is how we treat it, and is it still treatable? Those kind of things. So I have a couple of just so and you've heard me say this before. My family makes just such darn good coding examples, but my sweet little mother had Parkinson's dementia.
Oh.
Um, Before that, I did not know that dementia went with Parkinson's so strongly.
Mhm.
50% of Parkinson's patients will experience hallucinations. I
Wow.
really wish they'd told us that before we experienced it, so that we
Oh.
could have been prepared. And then, I think sometimes there's assumption that anytime an elderly person, loses their memory or talks kind of crazy, that it's dementia. We also, and my husband wouldn't mind me sharing this. We just walked through this with his mother.
Mhm.
We assumed it was dementia, and we're all ready to being a coder. I was going to slap that 403.90 on there, and when the neurologist saw her, that's not what it was. It was, she'd had some strokes, and that was kind of it was a cognitive effect from the strokes, which is not the same,
Wow, yes.
and the treatment is
Mhm.
not the same.
Yes.
So I think it's easy sometimes as a coding professional, or kind of if we're on the business end of it, to think, oh, that number's going to get it paid, but that's not telling the patients complete and accurate story.
That's true. That's true. And you just hit something on the head, Kim. As coders, sometimes we know enough to be dangerous because it assists us in our job. However, we have to remember that we're not clinical people.
Mm-mm.
And not to say that there aren't coders out there that come from a clinical background, but the um, the profession of coding itself
Mhm.
doesn't require us to have that clinical knowledge. We're only to follow the guidelines that have been set in front of us.
Mhm.
Um, Another thing that you'd said before we got on was, understanding those key words, because they make a difference in what
Mhm.
we're doing. But by no means do understanding the key words, the clinical keywords, does that give us that wiggle room. We still need to, from a coding perspective, stay in our lane,
Right.
so to
Exactly.
say. And
Exactly.
that's what the guidelines help us do. is they help us stay in our lane and to understand what codes we should be reporting. Um, One of the ones that always makes me laugh is the use, abuse, and dependence
Mhm.
in mental health and substance use disorders there.
Right.
So when do I use the use, abuse, and dependence? And that's not even something that I need to figure out,
Mm-mm.
because the guidelines do such a great job of saying, hey, if it's use and dependence, it's dependence. If it's
Mhm.
use and abuse, it's abuse. If it's, they give you that no brainer how to
Mhm.
assign those codes out. So important for us to know where to go to look for those answers.
Right. Yeah, to go to the guidelines and then think about what we're doing. Think about the story we're telling. And I keep
Mhm.
coming back to that.
That's
What
perfect.
story are we telling about that patient? In speaking about like the pain management space and kind of that correlation between the F's and the G's there,
Mhm.
I'm seeing cases where the patient is on long-term use of an opioid for a pain problem.
Mhm.
That is not a use, abuse, and dependence. And
Oh
so
my gosh.
sometimes the physician, even the wording that if we just pulled out that phrase and not looked at the whole context of it, that's so I have a friend and we go to Bible study together, and our big thing is we can't just pull a verse out of context. We can't just pull words out of context in that
Right.
because the physician may say opioid use. That does not mean it falls in the F codes. We look at the context. Why are we using it? What are we treating the patient for? Are we using this opioid to treat their pain? Then it's not going to be an F code.
Right.
What are you
I
saying
just
about that?
had
Mhm.
this.
Yeah.
I just had this in this audit that I was doing when, and they were using, the patient was taking something to sleep at night. Oh,
Mhm.
well, then that's a dependence on a sedative. No, because the doctor didn't tell me that they were going to have any withdrawals if they went off of it. They didn't say
Mhm.
that they were misusing it. They said that the patient was using the medication as prescribed and getting the desired result of the medication.
Right.
If there was if there were something, if the patient discontinues this medication, this is the problems that they might have. They didn't say
Mhm.
anything about that. They
Right.
just said they've been on it. They've been doing great with this sleep aid for the last however long.
Mhm.
So, understanding that the doctor may come to us and say, oh, but if she stops taking that, I always have to go back and say, doc, but you didn't say that in your note. And
Right.
unfortunately, there are no neurosurgeons out there processing medical claims. It's
Exactly. Yeah. Yeah. Yeah.
right.
Yeah. Exactly. Exactly. Um, think about all the coffee drinkers. Think about all the coffee drinkers in our area. I don't drink coffee, but are we all of a sudden going to say, "Ah, they're addicted to caffeine? We're going to give them that F code."
Yeah. But I've seen that happen when so I was working in risk adjustment back in 2017, and I saw a lot of that. I
Hmm.
saw a lot of caffeine users. If they drank more than 3 cups of coffee per day, you put them down as a dependence. But who's to say that they could just stop drinking coffee tomorrow?
Hmm.
They might have a headache today, and then tomorrow they're fine. That's
Yeah.
that's the end of it. Where's
e-
the dependence there? Where's the better yet? Where is the clinical indication that that dependence is something we're going to have to deal with? I always
Right.
look at diagnosis codes as what are you doing about it? So
Hmm.
if it is a caffeine dependence, then you as the provider, what are you doing about it? And
Right.
if you're not, because it's not something that you would do something about, then how do you justify the diagnosis that you're taking responsibility for?
Hmm. Exactly. And what are we saying about that? I- what I'm finding, and you may have seen this too, because you mentioned, Humana and some of the other payers you've dealt with, and I'm not picking on Humana
No,
by
no.
any means, but we will run across where someone has said, well, if they smoke 3 cigarettes a day, it's this. If they do this, or if they quit smoking a year ago, it's this. That's not in the guidelines.
Right.
Um, and we run across and the guidelines or we don't have a AHA coding clinic or
Mhm.
we don't have something that tells us to do that. Who made up that rule?
Right.
And I always tell folks, you need to be able to defend this. And saying that Kim Huey told me or Christine Hall told me to do it, that's not going to help you
No,
when you're
that's
sitting
right.
when you're sitting across the table from a Medicare auditor. You need to know why you said that. Now, and
Right.
and you've probably had this experience too, but I've testified at ALJ hearings
Mhm.
and
Yep.
some other kids. I had to show. where this
Mhm.
came from. Um,
Absolutely.
yeah, and so
Absolutely.
hopefully, the folks listening are not going to have to do that, but there's always the potential to have to know you did what you did. Well, you need to know why you did what you did, but to defend why you did what you
Right.
did.
And that always takes us back to authoritative sources. And I'll say it until I'm blue in the face. You have to read the guidelines. You have to be able to quote something. And I always tell my providers, if you've been taught that that is clinical standard, then just give me a quote, AMA publication XYZ, or
Mhm.
APA, third quarter publication stated this advice for assigning this diagnosis, or AHA. Give me something to work with.
Mhm.
Otherwise, remember that your neurosurgeon colleagues, they're not processing claims for you.
No, they're not processing
So,
claims, and they're not gonna help you pay that money back when somebody comes to take it.
yeah, yeah. And then
And
that's
I
really what we're talking about, is the
Yeah.
business part of medicine. And that's what we use the codes for, is for reimbursement purposes. And, we have to be careful. We have to be careful with our Medicare money. We have to be careful with our premium money. I mean, I don't know about you, Kim, and I don't mean to go off on a shoebox, but I noticed that the more people that are now have access to healthcare, the premiums have gone up for healthcare to
Yes.
cover the cost of those folks getting healthcare. And I'm glad
Mhm.
they do. I'm not complaining by no means. And
Mhm.
um, but I think we have to remember that if we have people that are maybe not coded properly,
Mhm.
that are misrepresented with diagnosis, that are not necessarily supported through the guidelines or through other authoritative sources, that's going to end up with
Mhm.
costs that bring up the prices of a lot of things.
Well, and there's that aspect of the money, and that's probably the bigger pot and the bigger things we think about. But you've probably noticed the last, I don't know, 2, 3 years, we've gotten a lot of codes for things that are very, whether we call them orphan diseases or whether we however we talk about those, we have codes for things, and we're so focused on, or I shouldn't say we, I sometimes so focused on making sure I have the right code to get that claim paid. I forget there are other uses
Mm-hmm.
for the ICD-10 codes. How do we know how many people have this disease and how much money should be allocated to research for this disease if we don't quantify that disease? So there's that aspect as well. And that you may think, oh, that's okay. I don't know anybody with that disease. Well, let your grandmother get it, or your granddaughter, or your somebody, and it's like,
Right.
we want all the research possible. And we just, I keep going back. We want the patient to have the accurate story. We want to be able to
Absolutely.
look and see, and you've probably done this too. When somebody says, "Well, Christine, what do you do for a living?" You have to explain what codes are.
I
Well,
know.
there's a code for what's done. There's a code for why it's done. And then when we're telling physicians, again, I'm older than you are. I remember when there were words on claims. We had codes, but we had words as well. And they actually looked at the words. There's no words anymore on the bottom half of that claim.
No.
And so if we don't have that code, we don't have the we're not telling the whole story for lots of reasons, for all
Yeah.
the different reasons we've kind of talked about. So,
Absolutely. But on the other hand, I see that there are more and more people that are going to school to learn
mhm,
coding. They're becoming certified through national organizations to prove that they understand the concepts of coding. I don't know about you, but when I teach and I get lots of questions, well, is that going to be on the test? And that's I say, listen, the test is to make sure that you understand the concepts or the
mhm,
guidelines or the responsibility in coding. It's not that you can open the book and find I-10. It's
right.
about, what do you do when it's associated with another condition? And where do you look for that? And how do you sequence that? And what's that documentation need to show you to make that relationship happen there?
Mhm,
That's what the question wants to know, not about
exactly.
I-10.
No, exactly. And I don't know if you've seen this lately, but I'm getting calls and emails from former students or clients where the payer is denying a diagnosis code or saying it's
Mm-hmm.
inappropriate. And when I go look and I go, well, they're right. Well, how do you know that? Well, I went to the guidelines. So I'm finding, and it used to be that the payers didn't necessarily seem to know the guidelines and the all like
Mm-hmm.
we did. I'm finding it's the other way around sometimes now, where the payers are on top of it.
Yep.
and whether it's to save money, ultimately or not, they know the guidelines. Um, I had a pain management client that she says, Kim, I can't find anywhere. I've looked all over the Medicare website why this code is not correct. And I said, did you try looking it up again and looking in the guidelines?
Yeah.
That's where it is. Oh my goodness, I forgot all about that. I'm using my cheat sheet.
Now, it's to sit in court and have to defend what is this? It's called a, oh, wait a minute. Nobody
I love
wants to
that.
be in that position, right? Um, no, but another thing that I tell people when they're starting to ask those types of questions, I got this denied, I got this denied. They're saying it's not medically necessary, or it's investigational, or it's experimental. And I'll say, do you know that there are literally thousands of codes in ICD-10 that cannot be primary codes? And many of those codes don't start with a Z.
Mm-hmm. Exactly.
And they'll go, what? And I
Mm-hmm.
have a presentation that I do on denial management, and I show them a wheel of codes that do not support first listed or primary diagnosis codes.
Right.
Or we find that on the claim, they are assigning A, B, C, and D to every line of business, regardless of whether or not that A, B, C, or D diagnosis code supports the procedure that was done.
Mm-hmm.
So they're not assigning the right diagnosis pointer to the
Mm-hmm.
right diagnosis. And that's going to make a difference too. Like you were saying earlier, we used to get paid for procedure codes for whatever diagnosis you would put down. But nowadays, the insurance companies are sticking to their guns. We said, these are the diagnoses that support medical necessity. If
Right.
you don't have this diagnosis here, or if it's not presented the proper way, right, code first, or use an additional code to support other.
Mm-hmm.
Then they're going to deny those claims.
Right. And I know we're focused on the guidelines, but like the excludes notes,
Mm-hmm.
and yes, those are all in there in an encoder if you look for them,
Right.
but they just don't come up. So oftentimes we're using an encoder just like we would use just the index. That's kind of it works that same way, and we're not looking at that. Like you said, the use additional code, the code first,
Mm-hmm.
and just the remembrance of which comes first. And of course, I think we've kind of focused on the chapter specific guidelines
Mm-hmm.
in our discussion so far, but we've got those other guidelines,
Yeah.
and then the guidelines for the outpatient. We've got all those that we just have to stay on top of to know, the excludes one, excludes two. What are those conventions when it says use additional code? How do you know which one comes first? Well, it tells you that.
Additional.
Yeah. And code first. Hello.
Oh,
Code
I know.
also. Yeah. It just and I get it. I told you earlier, I didn't even have both pieces of the book. I started in this field when you had to buy the
Yeah.
book separately. I only had half the book, but plus I was just handed a book and said, "Here, use it." I was not told anything. So I think we do have the benefit now of having
Mm-hmm.
those guidelines online,
Mm-hmm.
searchable, and if you're using a book, which yes, please, if you're using a book, then you've got them there.
Yeah.
A few years ago, we had the issue of where the guidelines were updated so late that the printers didn't get them in time. You remember that?
I remember
So,
that year.
so but this year we hadn't had that problem again. So this
No,
year we have the guidelines, and
we have the guidelines way before we get the book.
mhm, exactly,
Yeah. Yeah.
exactly,
So
and
most definitely.
And another reason I like to get them, download them from the CDC website is you can easily see what's changed. You can see the highlighted,
Absolutely.
yeah, yeah, the bolded text. So, to stay on top of it. But and you've probably done the same thing. I tell everybody every year, October 1st, every year, April 1st now too,
Mm-hmm.
look up every code again.
Yeah.
We're not going to call it a cheat sheet. What do you call it there? You told me. I can't remember.
We
You
call
don't
it
call it a cheat sheet.
a
A
resource
resource.
tool.
A resource tool.
Mm-hmm.
I loved that. We kinda started throwing that around. Um, those are great. They're time savers, and
They are.
I mean, face it, coders in many cases are under production standards. They've got to get this many claims out, and
But they're only good depending on the accuracy. And so
exactly.
you have to make that conscious effort that at least twice a year,
Mhm.
before October 1st and before April 1st, that you're going to go through and see how to update your reference tool.
Right,
It's
exactly.
only as good as your data is. Um, I think I've shared with my friends before, but I had this happen way back in 2008 when the practice management software that I was using, they were charging us every year to update the ICD-9 codes. Now, there weren't a lot of changes to ICD-9 every year. It was, a few, usually less than 100. And the amount of money they wanted to update the software was ridiculous, in my opinion. So I chose not to update the software. Also did not think that I was going to have any changes to my codes because I was working with specific specialties that just didn't really get a lot of change. Boy, was I wrong. So that year, I think it was 2008, in November, I get a letter from Medicare and it says, Christine, you sent us 150 claims for constipation. And that code had been revised to a 5-digit code from a 4-digit code. And we want to know why you wasted our time and money processing all these claims. I know, and it was a little harsh, but
Wow.
I needed it. And so from then on, it was my goal and my mission to always look at the new codes that are coming out and they're coming around, and not just look at the new codes, but get to know those codes, get to know what they mean. What does hemolytic uremic syndrome mean?
Yeah.
Right?
Yeah.
I don't know,
And
but
we're
I look every year.
And we're enough of geeks about it. You don't mind me calling you a geek.
Not at all.
I'm not on the clinical side. I dropped out of pre-med. I decided, and I don't want to see pictures of it. I don't want to do it, but I'm really interested in it. And the best place to get that information we were talking about is in the proposals every year. And I don't know that, things are not ever going to go back to the pre-COVID. I wanted to go to Baltimore to attend one of those meetings in person, and then of course now we can watch them live on
Yeah.
YouTube.
Mhm.
And we can read the details of why we needed this code, and we learn so much about the disease processes. I will
Yes,
say that
absolutely.
sometimes, yeah, I will say that sometimes I regret not focusing on that back when I was teaching coding, not focusing on, hey guys, you've got to learn about this pathophysiology, the fancy
Mhm.
word for how things work. Um, we just have to focus more on that. And I think, and I know we're talking about ICD-10, but I think it dovetails into the new evaluation and management structure.
I love the marriage when
Mm-hmm.
as far as the problem complexity and diagnosis
Exactly.
coding, I think that is the perfect marriage.
Mm-hmm. And exactly, and it makes us better, more well-rounded coders, coding professionals. But you gotta understand, and so the basis of it is understanding that pathophysiology. And
Mhm,
then, yes,
mhm.
then we'll have to go to the ICD-10 guidelines to get that correct. But that's gonna help us understand that, complexity of the problem. So,
It's funny that we're talking about that. I know that we'd mentioned before, um, the clinical misconception of chronic, and
mhm,
that to kind of wrap up our talk on the guidelines, especially in the neuro section, that's one of the things that they mention a couple of times is chronic. When does something become chronic? And clinically, there are some key points when something becomes chronic, but from a coding perspective, coders can't apply that same
mhm,
knowledge of chronic. So you can't tell me that if something is there for 3 months, then it's no. It's when the provider uses the word chronic, when they
mhm,
have determined that that sinusitis is just not going away, and that's
mhm,
going to be part of what we treat on a regular basis for this
right.
patient. And same thing with the pain or chronic pain syndrome, whereas all those other little tiny signs and symptoms that together they make that syndrome,
Mhm,
that we need to remember that that's going to be told to us by the provider.
mhm. And again, looking in context because chronic. So for the new chronic pain management codes, it is
Mm-hmm.
3 months. That's that expectation. But again, we can't take that and go, oh, we saw they first had a visit for this 3 months ago. We're going to go there. Yeah, exactly. They've got to
Right.
say it. We can't make up it, and we can't not take the definition in one area and plug it over here in this other area.
That is priceless information.
Mhm.
You can't pull it from one hour area and plug it into another area to make it fit.
Mhm.
Um,
Exactly.
I tried that when I was a teenager in high school. My parents were real quick to let me know that no, the liberties that you have in one area do not extend into another area.
Yeah.
I think I
Yeah.
had 3 weeks to think about that one time. Well, Kim, our time is already up. I
Wow.
can't thank you enough for coming on with me today and talking. And I want to let everyone know that if you have any questions about what we talked about today, please reach out to Kim. She is an absolute wealth of knowledge. I met Kim face to face this year, but we'd talked before, we'd known each other, but face to face on Cruising with the Coder. So I want to invite all of you to look into Cruising with the Coder. We had a wonderful 8-day cruise where 3 days of the cruise was a conference. We talked about coding, all the coding updates that came about, E&M, ICD-10, CPT coding updates. We also talked about all CDI
Mhm.
when it comes to selecting diagnosis codes. And Kim is a genius when it comes to that. And then we also did some hands-on coding. So we were looking at Mohs surgery. We were looking
Mhm.
at different coding scenarios and how you would come to those determinations, whether it needed a modifier or how many units something would require. It was incredible. There are a limited amount of cabins available for this coming year.
Mhm.
This year, we're going to be on the Carnival Mardi Gras. I'm
Yay.
so excited. It's
Yes.
a beautiful boat. We actually saw the Mardi Gras as we were pulling out of port,
Mhm.
and it was unbelievable. So for those of you that need CEUs and you love cruising and you love exotic destinations, I think
Mhm.
this year we're going to Puerto Rico, the Dominican Republic, and to the Grand Turks.
Mhm. Yes.
So I want you all to reach out to Don the Cruiser. He is the one who is coordinating all of the bookings for the cruise. Make sure you secure your seat. And we look forward to seeing you guys there.
Yes.
We're going to have a ball.
That's gonna be a lot of fun. Christine made it so much fun this year. This is our 16th year, so we're looking forward to, Christine joining us. That's gonna be so much fun.
Absolutely. I cannot wait. Thanks again for coming on the show
Yeah,
today,
thank you.
Kim.
I enjoyed it.
Thanks. And I
Thank
will be
you.
seeing you soon. I think
Yes,
you and
ma'am.
we've got a couple of other things going on
Yep.
this year, don't we?
I'll see you in a couple of weeks, I think it's gonna
That's
be.
right.
Yeah, yep.
We'll be
So,
out in California together at the Healthcare Compliance
yeah, 2 East Coast
Association's.
girls out there. Yeah,
Yes,
that'd be a
it's gonna be
blast.
great.
Okay.
Thanks a lot, Kim.
Thank
I'll
you.
see you, and I'll see everyone else in 2
Yep.
weeks.